சரி ஸ்டார்ட் பண்ண சொல்லிருங்க.
ஆமா சொல்லிட்டுமா நம்ம சார்
சார் டீன் சார் எங்க சார் டீன் சார்
அவினாஷ்
அவினாஷா சார்
நீங்க ஸ்டார்ட் பண்ணுங்க.
அவர் வரணும் சார்.
ஓ சரி அவர்கிட்ட பேசிடுறேன்.
பேசிடுங்க.
நெட் இல்லையா? ஹலோ சார். ஓகே 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 சார். No problem, no problem.
என்ன சார்?
1 minute join பண்றாரா?
Okay. We'll wait 1 minute.
Hello. என்ன?
Good evening, everybody. Good evening, Panjwak sir.
Good evening, sir. Dr. Anburajan, sir.
Yeah, Anburajan sir.
Sir.
Are you back to India?
Yes, sir. Yes, sir. Yes, sir. I am.
Yeah. Panjwak sir.
Bonwe sir, am I audible, Bonwe sir?
Yes. I'll just introduce this thing before we start our meeting. There is Dr. C. Anar Basu, who is our National Secretary of IMA CGP. Dr. Amburajan is there. He's Joint Secretary. Right now, he's in Sri Lanka. He's joining from there. Then Dr. Rekha, who is the Joint Secretary of IMA, and she will be conducting in all. We can see around 18 people have joined right now. We have around 75 plus today. So we can wait for a minute and we'll begin.
Sure. How is the situation in Sri Lanka?
Sir, as such, it was very, terrible since yesterday, up to yesterday afternoon, sir. The thing is, the public, especially the youth, they have taken the whole thing, controlling everybody in the street, especially in Colombo, Vatala area, that is the airport area. So they have been there for a long period protesting against the and the Prime Minister insist them to leave the government. The people were nearly more than some 10,000 to 50,000 people. It's a mobile, all youngsters, boys and girls. They were on the street. They were stopping every vehicle and inspecting every vehicle, and after seeing is any from the government inside, they won't allow, they will beat. And otherwise, they will allow the vehicle. That was the situation. So they demanded Rajapakshe's,
Resignation.
resignation as immediately, and asking him to go away. But
So you
what
are safe there? You are safe there?
To make the situation a little control, Rajapakshe announced his resignation. But in the meantime, he brought the people from the jail, the prisoner, out, some 2,000 people, and give them some money, and then send them to go into the crowd and beat the people who are protesting. So that because of that only the problem become very big. And Rajapakshe went to Anuradhapuram, beyond Trincomalee, and where there was
Deepan, you are this thing, ये administer कर रहे हैं ना वो people to let.
Okay. So because of that only the riot started, and they were started burning houses of important people. So,
Unfortunate situation.
yeah, very unfortunate, sir. But still the people are starving, and there is no petrol, no diesel, no kerosene, no food, proper food, groceries, not enough. And the situation is becoming worse and worse. In the meantime, to make the people, while these youngsters were doing all these things, the army and the police are just watching them, that's all. They're not doing anything. They were not able to do anything against the people. Like one incident happened in Tamil Nadu during the Jallikattu, you might have heard about it. The youngsters come from all over Tamil Nadu to Chennai to do a protest. Likewise, it was going. All of them were youngsters on the street continuously 24 hours protesting against the government. But finally, the president announced that Ranil Wickremesinghe will be the alternative arrangement, and their demands were two. One is president was having all the power, and that also they wanted, the protesters wanted to remove that part of the law, and then he has accepted for that. And from yesterday, then the Human Rights Commission, they took over the situation, and they asked the police and army to control the situation. That's why they announced to shoot the people who are burning or doing any harm to the public property on the spot.
My God.
So after that, it has come to a control. Only because of this, Rajapakshe, he brought people from the prison to beat these protesters. That only made the situation, aggravated the situation, and this bannings of houses and properties.
Yeah. You're back now, sir. Anburajan, sir, you're back. You're back to Chennai.
Yes. On the way, sir. I'm on the way.
Yeah, okay. So you're safe. Huh?
Yes.
That's very fine.
Yes, sir.
Now it's almost 9:10. Dr. Rekha ma'am, Dr. Anabasu, sir, we can begin.
Yeah.
Shall we start?
Yes.
Okay. Good evening to one and all. on behalf of IMA College of General Practitioners Headquarters and Synapse Brain and Spine Foundation, I welcome you all to this online lecture series on brain and spine problems for primary care physicians. Esteemed speaker, Dr. Jayadev Panchwag of Indo-German Neurosurgery Foundation is here with us to enlighten us. Over to our Dean, Dr. Avinash Bondwe, for his address.
Yeah. Before that, Dr. Anbarsu, our secretary is there. I would...
Sir, good evening, sir. Good evening to our beloved Dean and Anbrajan and Rekha. Our Dean is taking an excellent effort for all the CGP members to empowered with many topics and many subjects. It is really a boon for all the general practitioners to learn all the basic things of everything in a short way, which is useful for the general practice. CGP must be really thankful for our Dean for the beloved work and the nice work which is happening now, which is useful for all the general practitioners. They must really make use of this situation. And it's a nice thing. All the topics given are very nice. And I must really thank Jayadev on behalf of CGP. Now I request our beloved Dean to talk. Thank you, sir.
Thank you. Today's speaker, our good friend and a very eminent neurosurgeon from not only from Pune, but from all over India, Dr. Jayadev Panchwag, our honorary secretary, Dr. Anbarasu, our joint secretaries, Dr. Rekha, Dr. Sanjay Patil, and of course, Dr. Amburajan, and all the delegates who are attending this very important lecture series on spine and brain. Dear friends, as you all know, IMA College of General Practitioner is basically taking pains to upgrade the knowledge of all the general practitioners, as well as to groom the skills which are required for the day-to-day general practice. We have been taking many courses on newer things, as well as from the routine things. We had one session on burns, one on psychiatry, one on a very important topic of genomics, and now this neurosurgery spine and brain lecture series we are taking. This is for the first time we are trying this. We are rather having 8 lectures in this, which are very, very interesting and which will be directly useful in our day-to-day practice. I would say that if you attend all these 8 lectures, you will find the difference in your practice. You will appreciate whatever the clinical acumen is increased. This I talk from my personal knowledge that long back in 2004, when I was assistant director of IMA CGP Pune sub-faculty, that time we had arranged a similar lecture series of Dr. Jayadev Panchwag. And I realized that a lot of patients we see in our day-to-day practice, how they should be tackled, how should be, what is their diagnosis, differential diagnosis, the treatment, and all these things. Dr. Jayadev Panchwag is MBBS, MS, and of course the MCH neurology. He has taken his training in under Dr. Pandya at KM Hospital, Mumbai, which is rather he's very proud of, and we are also very proud of. He has taken his training in NIMHAUS also, and he is also founder of this spine and brain foundation, which is the Indo-German foundation actually, and the trust name is Synapse Brain and Spine Foundation. This is an Indo-German effort, which is the counterpart of Neurochirurgisch Health Indian. Dr. Panchwag, please pardon me for my pronunciation of German pronunciation. Maybe is it Neurochirurgisch Health Indian? Am I right?
Neurochirurgische. Yeah, it is German program.
Okay. Yeah. So it is all these things we have to learn along with the neurosurgery, German also. And he is dedicated to excellence of neurosurgery. This foundation, he has been taking so many programs, as well as he has been operating and treating many patients, not only from Pune and region, even the national level and international level. He's operating many patients. He's a very, I will say, general practitioner, friendly surgeon. Friendly means whenever we have any problem, we send patients to him. And I'm very proud that whenever the surgery is not required, Dr. Panchavag himself says this person does not need any surgery, which is one thing which we always rather stress all the ethical part of our practice. So I'm really very happy that this Dr. Panchavag is always carrying out all these responsibilities very well. And I'm sure that these 8 lecture series will definitely have a good amount of knowledge as well as the part of his experience, which will be rather inculcated in our knowledge, and will definitely find the difference in our day-to-day practice whenever the spine and brain patients come across. So with this, since we have 8 lectures, so this time we are just introducing. From next time, we'll just invite you, sir. And I'm sure that today we had maybe a little less this thing. There are 75 members who are registered, who are listening and attending. But at the same time, I will like to remind all of you, all the attending delegates, that on 19th of May, that is the next Thursday, the coming Thursday, one day before our next lecture, we have International Family Doctor Day, and which will be rather, there is a very big program we have organized on behalf of IMA CGP National, a CME as well as a very good few lectures will be taken. The program will be hosted by IMA Mumbai West, and there will be a lot of eminent speakers as well as CME. So please do attend. We'll be sending the invitation of that in a day or two, and definitely I'm sure that all of you will attend it and will get definitely a different aspect of general practice. So with this little bit introduction, over to you, Dr. Jaidev Panchavag, sir. Thank you.
Thank you, Dr. Bhunve, for very generous introduction. So I will try to do justice to your expectations, and I thank all the office bearers for inviting me to give this lecture series. I think it is very important. Can I share the screen now, Aditya?
Yeah, sure, sir. Please go ahead.
Can you see it now?
No, we cannot see. Just hit the green button on Zoom and select the PPT. That's when we will see.
Yeah, I have hit the green button.
And then after that,
share, right? Okay.
Yes.
Okay, now
yes. Yeah, we can see now.
Clearly, right?
Sir.
Yes.
Okay, so just give me a second. Is it good now? You can see the screen completely?
Yes.
Okay, so I intend to talk about the topics which are commonly seen, and spine problems are very common, as you all know. Dr. Bhunve has already introduced me, so I will skip this part. Presently, I operate in Sahyadri hospitals in Pune and in some other hospitals. We have a very dedicated programs, especially for trigeminal neuralgia and hemifacial spasms, which gets patients from all over the world actually, and also endoscopic spine surgery. So as those topics come, I will speak on them more. So there was a time, as Dr. Bondwe was recollecting, that I had given this lecture, I remember, and I have taken this slide, right from that lecture, and I had called it the headache of backache. So backache is the biggest headache that one gets in life, because it is a very, very common problem. As you all must be knowing by going by your practice, this is perhaps the commonest problem with which, that is pain problem with which a person comes to the clinic. And jocularly, it has been called as the most effective contraceptive in India. And going by statistics, more than 90% will have back pain sometime or the other. I think it is more than 90%, but this is from one of the papers, this statistics. So it is very common, without any doubt. Very common problem, and I think very commonly undiagnosed, misdiagnosed, mismanaged, incompletely diagnosed, etc. And we all, remember a patient who comes to our clinic when we are very tired, and this is the last patient, and he comes to the clinic and then he starts giving all the history of back pain, and he says, I cannot get up, cannot do this, cannot do that. And then we simply take out a prescription pad and write analgesic and just wish that this person goes away. Because, these are very non-specific sounding problems which these patients tell us. But are they really non-specific? That is what we have to really remember. The first thing that I would urge, and again I tell people to differentiate in your mind, at least once you see a back pain patient, this is the first thing you should do. And you have to answer this question from what this person is telling, whether this is a simple back pain or common back pain or serious back pain. Now, I will tell you what I mean by that. So serious back pain, in nutshell, okay, these are not the rules, but these are the pointers. It usually spreads to other areas, it doesn't remain restricted to the low back or mid back. Then if there is bladder involvement, if the patient says there are urinary problems, certainly you have to really, start hearing properly all his complaints. And then there are some red flags which you have to remember when a person is telling you about his or her back pain. So what are these red flags? So red flags are recent trauma, history of recent trauma, which starts back pain. One has to be careful when one is, just prescribing simple analgesic. If the back pain is not relieved very easily on supine position, he says, I lie down for sleep, but my back pain continues. It is possible that it is serious. Pain that awakens the person at night, classically, it has been described in patients who have spinal tumors, and not always, but in sometimes even in infections, you will get this feature. That is, the patient gets up because of back pain at night. Now, if this complaint comes, one has to be really careful. If the back pain is associated with weight loss, one has to be really careful. If it is associated with fever, certainly you have to be careful. If it is rapidly increasing in intensity in spite of analgesics, one has to be careful. And lastly, if the person has, even in the even in the past, a long time ago, even the person has a history of cancer, you have to be careful in the back pain patient. So sometimes people forget about their history of cancer, especially ladies with breast cancer or some cancers which have, they think they have been, cured. And after 15, 20 years, they get back pain. You have to really ask them the history, whether there is any history of, specific pointed question, whether there is any history of tumor or cancer. Now, common causes of usually non-serious. I say usually non-serious because sometimes these conditions can also become serious. Okay, so the common causes which are responsible for low back pain or mid back pain are myofascial pain, that is pain due to muscle spasm or the facial insertion in the bone getting irritated. Then facet joint pain, disc prolapse, early stages of disc prolapse, or herniation giving rise to back pain. Spondylosis, early or advanced. Spondylolisthesis, when one vertebra slips over the other vertebra. Sacroiliac joint pain. Now, this pain is very, very commonly ignored, and many a times the diagnosis is sacroiliac joint pain when the patient is being treated.
Audio is not good, sir.
Now you can hear? Can you hear now?
I can hear, sir.
Yes, we can hear you, sir.
Yeah.
Okay.
Go ahead. Yeah.
So, spondylolisthesis, sacroiliac joint pain. Sacroiliac joint pain is a very common pain, which is misdiagnosed as disc pain. Early osteoporosis or even late osteoporosis can give rise to back pain. Serious causes, of course, are spinal tumors or metastasis in the spine, infection, compression fractures by minor fall can give rise to pain, especially in elderly persons who say that it was a very minor fall, and after that I have got pain in the mid portion of the back. These are commonly compression fractures in elderly people. Lumbar canal stenosis with impending neurodeficit or disc prolapse can become very serious at times. So there are some problems which can mimic or can cause back pain, like hip joint problems, pelvic organ diseases, especially in women. Also, heart problems can give rise to back pain, as you all must be knowing, because this has been told repeatedly that is approximately interscapular area. That is the area where people complain of back pain in heart problems. In pancreatitis, you get boring pain going to D12 or L1 area in that region somewhere. Retroperitoneal tumors can give rise to back pain. So there are some other problems which are not directly related to back, that is spine, which can cause back pain. That is something you have to really remember so that you will not miss important diagnosis. So it is very important to diagnose the specific cause or pain generator in back pain. So for that, one has to remember a few concepts. The first concept is that one has to remember that entire spine is one organ. Though we tend to divide it for convenience in cervical spine, in thoracic spine, or lumbar spine, sacrum, it is actually one organ. These vertebrae are working in unison. And if you look at the muscles, you will realize that they go across the joints, and that is why sometimes a person with cervical spine problem can complain of mid-back pain, because the muscle insertion goes right down. So this is first thing one has to remember. So when one is examining low back pain, the entire spine should ideally be examined. Second concept one has to remember is the process of spondylosis. Now, many people misunderstand this word. So spondylosis is nothing but, like graying of hair. I tell people that like hair gray, over the period of time they become gray. Spine also becomes old, and that process of becoming old is spondylosis. How does it start? It starts with a normal disc here, normal disc height reducing. You can see here the disc height has reduced. So these two vertebral bodies have come near to one another, and the body realizes that there is some abnormal movement occurring here because of change in the disc height, and the body sends more and more calcium there, and osteophytes are formed. And you see here in the down here that these are the osteophytes which have which have formed here and which have started compressing on the nerves, etc. So this is a spectrum of development of spondylosis. So you see, spondylosis is not actually a disease in itself. It is a process, but it can become a disease. So one has to really be able to diagnose when a normal process of aging of spondylosis becomes a disease. And that is when the symptoms start, increasing. So this is next concept. The third concept that one has to remember as to the commonest cause of low back pain, it is a discogenic pain. Now, as we all know, the disc is made up of two parts. The outer part is annulus fibrosus and the central part is nucleus pulposus. And with aging, what happens initially, if you look down here, some fibers of the annulus fibrosus are torn and some portion of the nucleus spreads amongst these fibers. Now, this tear over the period of time goes on increasing, and after some time, there is a complete tear and portion of the nucleus pulposus comes out. And this is the time typically when people say that the back pain or low back pain has suddenly disappeared, but now we have a radiating pain like sciatica because this disc has ruptured. Intradiscal pressure has got dissipated because the disc has ruptured. So the back pain suddenly reduces in intensity, low back pain I mean, but that is replaced by a buttock pain which radiates down to the posterior thigh and then calf. So this is a typical story given by these people. But there is a phase before this rupture when people keep on getting only low back pain because of the disc prolapse, which is still inside the confines of the disc, but the soft material has prolapsed in the annulus fibrosus. So I want to draw your attention here. As you can see, this is a diagram of disc prolapse, and this pink nucleus has prolapsed and it is trying to come out. Normally, the annulus is not innervated and the disc is not supplied by blood. Okay, the nutrition of the disc is by diffusion of the nutrients through the end plate. So, disc normally in normal state is not vascularized at all. Only the anterior portion of the disc has got some nerve fibers just to sense, the pressure inside and give feedback to the brain. But when this tear occurs, what happens is that the material starts coming out or oozing out between the lamellae. And this material is antigenic. So the blood vessels grow inside the disc now. There is inflammation and there is pain, that is back pain. So this, though the disc is still inside its own confines, the back pain will start. So this is the discogenic back pain that one has to remember. And of course, the further stage is, the portion of the disc coming out and then compressing on the nerve root and causing sciatica. But before that, as I was telling you, this vascularization and back pain starts. Now, the spine anatomy or pathology is described typically with the help of spinal unit. Now, this spinal unit is two vertebrae with the disc in between and the nerve roots coming out in between the two vertebrae. As you can see here, the disc height has reduced and osteophytes have formed and the nerves have started getting compressed. So this is a pathological stage of spondylosis. Now, because of the spondylotic process, even the facet joints which are behind between the two vertebrae, they also get inflamed and people start getting what is called as facet joint pain. Now this pain, facet joint pain, is typically just on the side of the midline, and person will tell you that the pain is maximum when there is extension. If he tries to do, typically these people are told to do Bhujangasana, the exercises where you put your back into extension, and they say that when I start doing this exercise, I get severe back pain. My back pain gets aggravated. That is because Bhujangasana is good for discogenic pain. But if the person has facet joint problem, this exercise is contraindicated. So another reason why you have to really put your finger on what is actually causing the pain and giving rise to, such chronic back pain, so that you will prescribe correct exercises, advise correct surgeries, advise correct treatments. So pain generator definition is very important. Myofascial pain, of course, as I told you, is one of the commonest, and which is called as typical lumbago. Quadratus lumborum is the muscle which very typically gets sprained, and usually this pain responds to analgesics and hot fomentation. It lasts for 3-4 days and then reduces. Now, spondylolisthesis, this is something that one has to remember because this concept is for some reason not known to many people, but the problem is very, very common. As you can see in this diagram, one vertebra is slipping over another. This is called as spondylolisthesis. Listhesis means slipping and spondylos means vertebra. There are various reasons for this. Some people have congenital weakness in the posterior element. So this is a posterior element of the spine and there is weakness, or this part is not formed properly. So as the age advances, the muscles become weak, the vertebra starts slipping. Another reason is what is called as Parse fracture, that is fracture of this area, especially happens in hyperextension. And then this vertebra starts slipping in front and the process of spondylolisthesis starts. The spondylolisthesis can also occur in advanced spondylosis, the process of spondylosis, because the ligaments become weak with age. What happens in spondylolisthesis, the typical history is that the person says that when I'm standing, after about 5 or 10 minutes, the back pain becomes very severe and I feel like sitting or actually sleeping. The women tell us that when they're making tea or coffee, they cannot stand more than 2-3 minutes and they have to sit. So this is very typical of spondylolisthesis. Also, it causes neurogenic claudication, that is numbness and sciatica-like pain in both the legs when the person starts walking or stands for a long period of time. I'll speak about sciatica and neurogenic claudication in next lecture separately, because that concept again needs to be understood very, very properly, because these are very common problems seen in general practice. Spinal stenosis. So what is spinal stenosis? As you can see in this cross section, this is the spinal canal, and the spinal canal has got a wide diameter here. But if you come here, that's in the middle picture, you see this canal has reduced in diameter. It has become trifoliate. So it is like 3 leaves, and that is because there is a calcium deposition inside. The process of spondylosis, which has gone beyond limits and given rise to stenosis. This spinal stenosis also causes back pain. Here you can see that the portion of the spinal canal has become narrow. And spinal stenosis can cause other symptoms, of course, like neurogenic claudication, that is person getting heaviness, weakness, tingling, numbness while walking, and the person says that after some time he or she has to stop in between. So this is neurogenic claudication. So spinal stenosis has back pain as a component and neurogenic claudication. So you must have realized that though there are, similar symptoms like low back pain, mid back pain, gluteal pain, etc., the exercises and treatment which are advocated for different problems are different. Not only that, they can be sometimes diametrically opposite. Like I told you, in facet joint pain, if you ask a person to do extension exercises, the pain will aggravate very badly. In that case, you need to ask them to do flexion exercises. Similarly, in spinal stenosis, flexion exercises are required, not extension exercises. If the pain is discogenic, extension exercises are required. So the exercises are also different. So you have to remember that, because many times I see people going to physiotherapists and they are given some typical, diagrams and they are asked to do the particular exercises, and all of them are given same exercises, though they don't even know the cause of the back pain. And that is why these problems do not get cured or solved, and they keep on going to these people again and again. Now, another thing that one has to remember in this spectrum of pain, that is low back pain and gluteal pain, is the inflammation of sacroiliac joint. And sacroiliac joint gets inflamed in various conditions, different arthropathies, also very common in women after childbirth, because during childbearing, the ligaments become loose and there is malalignment between two surfaces of the sacroiliac joint, and there is abnormal movement and sacroiliac strain. There's no inflammation prima facie, but there is strain and there is pain. Now, why is it important? For two things. One, it is very commonly misdiagnosed as disc pain or sciatica. Sacroiliac joint pain is on the side of the midline at the level of L5-S1, and there is a tenderness on sacroiliac joint. If you put your thumb there, sacroiliac joint pain very commonly radiates in the groin. That is another indication that it is not disc pain. Disc pain very, very rarely spreads to groin, extremely rarely. So you can practically take it that it never comes to groin. Secondly, sacroiliac joint pain, though it is troublesome, it is not dangerous, but it is extremely troublesome. A person will come really shouting in your clinic, because of pain. The relatives will say the person is not able to walk, and the severity is very severe. It is dramatic presentation. However, it is not serious problem in the sense that it is not compressing any specific nerve. So you can diagnose it properly and treat it with various modalities. Piriformis syndrome is another rare problem. This is a rare problem. Sacroiliac joint pain is not a rare problem. Piriformis syndrome, typically, the person says that when I sit on a hard surface, my gluteal region starts paining and the pain spreads to the posterior thigh and then calf. It can appear like a sciatica, but there is tenderness on palpating the midpoint, mid portion of the gluteal region, and the typical history that if the person sits on a hard surface, there's a pressure on the piriformis and the nerve which is coming abnormally above or below it, then the pain starts. So what I mean to tell you is again and again is that exact diagnosis is very important. So back pain, you have to initially, everyone gives analgesics for a week or so, but if it persists and changes its character, then make sure that you diagnose why back pain is there. So come to exact diagnosis. Now, just to make this point clearer, I have included this MRI here. You can see there is a patient with L5-S1 disc prolapse, and this person was diagnosed at many places as pain due to disc prolapse, back pain with posterior thigh pain. Now, this person, actually, though there was disc prolapse, this disc was almost calcified and the nerves were not compressed seriously. And all the tests for sacroiliac joint were positive. So this person was treated. I treated him with, injections in the sacroiliac joint, and the pain just went away. So wrong labeling because of MRI showing a disc. Now, if you, perform MRI on 50 people who are walking on the street, you will get disc prolapse, which is seen in nearly 25-30 of them. So that doesn't mean that they have a problem due to these disc prolapse. So one has to remember that. Another concept that I want to make clear what is the relationship between body weight and back pain, especially the weight in the front, that is abdominal girth, or the pain, the amount of fat which is deposited in abdomen. Now, if you remember our school days, we were taught about a fulcrum concept, wherein there is a fulcrum here, and the length of these bars and the weight, there is a relationship. So similarly, spine is a fulcrum. So if there is weight which is anteriorly and which is trying to bend the spine down, then because this portion of the fulcrum is small, there is tremendous stress on the spine, and that is why the increased weight, especially anteriorly, especially in wrong posture, can cause severe back pain. So that is something which is very important, because you can show this to your patients and tell them this is why you are getting pain, and if you reduce the weight in the front of your body, your back pain will reduce. So in essence, the disc is like shock absorber. It is also a ball bearing. When you bend forward, this nucleus goes back. When you bend backwards, the nucleus goes front. So this is also ball bearing, but it is also shock absorber. So when it absorbs the shock, this disc reduces temporarily in height and bulges on both the sides. And when there is distraction, this opens. So this opens up again. Can you hear me now?
Yes, sir. Your video is closed, sir.
Sir, you are audible, sir.
You're audible.
Video is closed, is it?
Yeah.
That is sharing. Oh. Now you can see?
Yeah.
Yes, sir.
Okay. I don't know why it was shut off. Okay. So basically, you have to remember this concept very clearly, that in distraction, this disc is at rest. Okay, remember this. Because all the exercises, all the yogasanas, which aim at distraction, actually, they are very important. They are very important in reversing early stages of back pain. And distraction also is useful in increasing nutrition of the disc, because it is in distracted position that the nutrition flows inside the disc through the end plates. Okay, so this is a very important concept to remember when one is advising exercises to these people. I will show you 3 cases where unfortunately these patients went from one doctor to another, and just so that you won't forget these causes, this first person had pyogenic discitis, and she was given analgesics for a long time. Her X-ray was done. X-ray doesn't show destruction till about 30% of the vertebral body is destroyed. So one has to remember this. So if you look at a normal X-ray, it doesn't mean anything. If the clinical examination is indicating that there is a problem, then one has to either go towards MRI, CT scan, or some further investigation. This lady had pyogenic discitis, which needed, endoscopic drainage, followed by about 8 weeks of intravenous antibiotics. And she was cured with this. But before this, she suffered from back pain for a long time. So just to remind you that, there are sometimes serious causes of back pain which are ignored. Now, another person, who had visited multiple doctors only with low back pain, and he was found to have in the end a tumor, and the pain was because of the dural stretch. As the tumor was increasing, there was a dural stretch, and that was causing serious back pain. And actually, he was giving a very specific history that at night he was waking up due to the tumor. So just for interest, I'm showing this to you. This is after I have opened the dura, and you can see the nerve fibers here. And as I separate the nerve fibers under high magnification microscope, you will see a neurofibroma which is coming in the view. So this was a tumor which was distending the dural tube. It is a non-cancerous tumor, as you know, and it needs to be diagnosed in time and resected. Otherwise, it can cause problems to the surrounding nerves. So just so that you won't forget this possibility, I'm showing this video to you. This was adherent to one nerve because it was arising from this nerve. It was resected and this person was cured. So remember that, if the back pain is not relieving, one has to think of doing further investigations. This is another person, though this is a cervical area. This person came to me with, a long history of neck pain. And as you can see, there is a neurofibroma which is compressing the exiting nerve root. And after resecting it safely, the spinal cord and nerve roots are free. The dural tube, which was distended, is now back to normal. Now, this is a case that I want you to remember because very rarely these things can happen, but one has to remember this possibility, then only one can diagnose it. This lady had actually visited multiple doctors with recurrent attacks of neck pain and mid back pain. These attacks were repeated and over the period of 2 years, really. She was lucky that, she didn't die during one of these attacks, because when she came to us, she was in one of those attacks, and when I examined her for simple neck stiffness, there was neck stiffness on asking. She had photophobia. So we suspected subarachnoid hemorrhage, did angiography, and this is what we found. This is a posterior communicating artery aneurysm. Since it is in the lower portion of the brain, the blood spreads into the spinal canal rather than going up. And you can see the pulsations of this aneurysm, and you can see a thin portion. This is the medulla oblongata. And this portion is medulla oblongata, and here is spine. On this side is brain. This is cerebellum. And this blood was spreading in neck and the spine. The subarachnoid spaces the spine down. She used to get severe pain. And we diagnosed this aneurysm. So just to remind you that, and this is a clipping of the aneurysm near medulla oblongata. So just to remind you that sometimes there are serious causes. So one has to take history properly, even if it is a simple looking complaint like, neck pain or back pain, and diagnose the cause. Many people ask me this question, can spondylosis be reversed? So spondylosis cannot be reversed when it has reached, advanced stage, but its progress can be progress can be made slow, or it can be prevented from going to serious stages. So how do we do it? So weight reduction, exercise, posture correction, and relaxation exercises. So both are important, strength and flexibility. So aerobic exercises like walking or cycling, especially swimming. Swimming is a very good exercise for people with back pain, or walking in water is also very good exercise because there is no gravity acting. And in swimming, of course, the person is horizontal, so it is relatively safe to back. Then diet is important. So strength exercises, these are sometimes neglected. Increasing the strength and muscle mass and bulk of the back, not only in young people, but even in elderly people, you can choose less weights, but you have to train them, train the muscles. Walking, yoga, climbing stairs, or these aerobic type exercises are important, but these are also important exercises, and that's what has to be told to these people. They don't know about it. strengthening of the abdominal muscles is very important for the health of the spine in general. Flexibility, then training the extensors of the back and doing again flexibility. These are very important things. Another concept that one has to remember that is that the intradiscal pressure or pressure inside the intervertebral disc at L4-5 level was measured by a needle in one experiment, and it has been proven again and again, time and again, that maximum pressure is when the person is sitting, bending down and lifting up something in sitting position, sitting on a chair and trying to lift something. That is the worst posture that you can get for disc herniation. Intradiscal pressure is maximum. Lesser pressure is there in standing position. Even lesser pressure is there in lying down position, of course. The least pressure is in the lateral position while the person is lying down. So, sitting for a prolonged period of time with bad posture can give rise to discogenic pain, and eventually disc prolapse. That is what one has to remember. So, posture correction is very important. The way people lift up things, they have to be trained properly. And in cars especially, the lumbar support is very useful to keep the spine, to keep the spine from going in flexion. So keeping it in extension is important. Now, yoga is also useful in early stages, especially the asanas which consciously cause distraction between two vertebral bodies. These are helpful asanas. As you can see here, the asana known as Dandasana. This person is purposefully pressing her pelvis onto the ground and then distracting the upper portion of the spine, thereby causing discs to open up. So this is one of the important asanas. Adho Mukha Svanasana is also important for disc distractions. Urdhva Mukha Svanasana also, while this person is pressing the upper portion of the thigh towards the mattress, he is pulling this portion up, thereby distracting the vertebrae from one another. The entire Tadasana series is very, very helpful because it also causes distraction between the two vertebrae. Paschimottanasana is also very useful if done properly. Here, the bending is in the hips, not in the back. The back is straight, as you see here. Many people, bend here, and that is why that can aggravate discogenic pain. So many more such asanas are possible. And important to remember that these asanas are not just the bending exercises. One has to purposefully engage specific muscles with concentration and understanding. The upward spinal stretch is important and should be done very consciously. So a yoga spine program with proper understanding is very important, rather than, very loosely advised yogasanas can be detrimental. You have to remember that. Now, this is not the place to discuss surgery, but I just want to show you that the technology has reached such a level that, without incision, prolapse disc can be removed. And why I'm showing this to you, I will tell you after this short video is over. I'm going to, narrate you the story. This person has got severe low back pain, and off late it is, spreading to the thigh, and he has this disc prolapse here, and he didn't want open surgery. This was, the surgery was, endoscopic surgery was indicated. That is why he was operated under local anesthesia by putting in a scope and then removing portion of the disc which has herniated. You can go right into the disc and remove. The person is conscious. It is done under local anesthesia. And this is at the end of, this is a fragment removed. And 20 minutes after surgery, he is allowed to walk. Now, this is the kind of technology that we have now. But it doesn't mean that this technology should be used in all cases. That is something as general practitioners you have to remember, because there are many people who say that, oh, I do all surgeries endoscopically. It is impossible. Nowhere in the world all surgeries can be done endoscopically. There are specific indications. So I showed you this surgery that we do endoscopy, and still I'm saying that endoscopy is not indicated every time. You have to choose cases properly. Sometimes patients come to us and insist that operate me by endoscopy. So again, that is what, there the role of general practitioner is very important, to tell them what they should, want. What they should want is pain relief and increased quality of life. They should not demand the method of surgery. Method of surgery has to be decided by the expert, and the expert who can do both, not the expert who can't do one, and that's why says that I will do only this. So expert who can do both can take really good decision as to whether endoscopy should be used or not. That is something one has to remember as general practitioner. So take-home messages are low back and mid back pain are the commonest pain problems. So one has to know a lot about them, because you will get a lot of patients with this complaint. Back pain is often treated on symptomatic basis for too long. This is my experience. Stop in time. Stop treating only with analgesic after first 1 or 2 weeks. If the back pain continues, it is time to investigate. Development of spondylosis is a natural phenomenon as body ages. It is not a disease, but it can become a disease if it crosses boundaries. Disc, facet joint, and ligamental degeneration is seen in almost all MRIs as we age. So just because MRI report reads something doesn't mean anything. Whether it is correlating with your clinical history and examination, it is a very important question to answer. And indiscriminate surgery should not be done on one side, and surgeries where indicated should not be avoided on the other side. Then only the person can get good relief. The fourth point, take-home point, is important. Again, I'm telling you, find out the pain generator in time. Just don't keep on treating with analgesics. And other than abdomen, in no other problem, a good history taking followed by precise clinical examination is as important as in that in back pain. Sixth point is spinal surgery has technically evolved, but rather than insisting on a particular procedure, one has to insist on a fact that pain is relieved, that the procedure relieves the pain and improves quality of life. This is the rational expectation, which a general practitioner can many times help patient reach this conclusion and expect the outcomes like this. So this was in short about back pain. Back pain is a big issue, it's a big topic. Next time I want to talk about important symptom like sciatica, neurogenic claudication, all very common. So I think if you could request your friends also to join, it will be a very interesting lecture. I stop here, and I once again thank you all, and we will meet next week, next Friday, with continuation of this topic. So I will stop here.
Thank you very much, Dr. Panchavak sir. Can we take a few questions?
Yes, of course.
Yeah. Dr. Rekha, you have any questions?
There are no questions in the chat box, sir. Maybe they could raise arms and...
Yeah, if anybody is there, they can raise their finger.
Actually, this topic will be finished in next lecture. So even then, if they have back pain problem, we can take it that time also. There is no problem.
I would like to ask you one question, sir.
Only one question from me also, sir. After our question.
Yeah. One question rather I would like to ask Dr. Panchavak, sir, that you explained about the exercises. In some conditions, we have to do the bending exercises, and in some back pain, we have to do the what you say,
back bending,
back bending.
Bhujangasana like thing.
So just tell us the condition in which the forward this thing is clear, has to be done, and in which conditions the backward extension is required.
So in early phases of spondylolisthesis, when we teach exercises, where we teach forward bend, not complete bending, but slight bending with strengthening of the abdominal muscles. That helps in spondylolisthesis. Also in lumbar canal stenosis, forward bending is relatively safe, because you will very commonly hear the history from these patients that while I walk, I start getting pain in the legs. But if I cycle, I don't get pain, because while cycling, you bend forward. So that increases the spinal canal diameter. On the other hand, facet joint pain, it increases facet joint pain is also relieved by bending forward. But discogenic pain, when the disc is trying to come out, which is a very common type of pain, it aggravates while you are bending forward. So in discogenic pain, we always tell it, don't bend forward. So in that case, it is not only the extension, but distraction, inside distraction, that is helpful as exercise. So these are the examples of diametrically opposite situations, but many times the symptoms are very similar. So I see many patients getting advice exercises very loosely. Many patients just give on a chart and there are some diagrams drawn on the chart and they just pick it and they say that you do these exercises. So that is not the right thing to do. One has to diagnose the pain generator and then actually design the exercise program based on that. So that is why many times you might find that in spite of doing exercises, patients are not getting relief. So those exercises are not rationalized. That is why the exercises are not at fault. But if wrong exercises are done for wrong problem, then the pain will continue.
Sir, I am Dr. Anburajan, sir.
Yeah.
Hello.
Sir, number one is Sparrow spinal muscle spasm. Sir, how to diagnose it and what could be the signs and symptoms that we want to know, number one. Number two, in vitamin D3 deficiency, will it cause that tendinitis and they are more common in that causes any pain, low back pain because of that vitamin D deficiency, D3 deficiencies.
Correct. So spinal muscle spasm is typically what we call as lumbago, severe attack of lumbago. And you will get patients saying that I tried to lift up something heavy and my back has become so stiff, I cannot move, right? I mean, it is very severe spasm. Now, in these cases, what happens usually is there is a very micro disc prolapse, small disc prolapse, which happens inside the disc. That means the nucleus pulposus enters between the laminae of the annulus fibrosus, so which is surrounding in the disc. The disc is not bulged or it has not even come out, but inside the disc itself there is disruption. So if you look at the disc grossly, it won't be bulging, but inside there is so suddenly there is a catch because there is pain that happens because of this rupture inside, and the muscles go in spasm. They go in protective spasm because body doesn't want the person to bend forward and lift it up, and the body wants the person to leave that weight and just rest. That's why the muscles go in spasm. Now this is the history. In muscle spasm, when you see a case immediately, you will realize that the muscles are actually stiff. You can feel that stiffness. There is tenderness, there is stiffness. If you do any movement or ask a person to do any movement, he will scream. You must have seen many patients with severe muscle spasm, and these are the acute muscle spasm cases. In chronic spasm cases, usually there is underlying pathology like spondylolisthesis or serious disc prolapse, and there's giving rise to low back pain. And then the person says that my back is stiff and I cannot, really move very swiftly, or while I'm trying to bend, there is stiffness. Now, these are the common causes of muscle stiffness. In chronic muscle stiffness, it is important to relieve the basic problem. Then only relief. So that is something that one has to. Have we lost the video?
Yeah, you lost the video, sir.
Okay.
Yeah.
So these are the two common things. D3, the deficiency of D3 and B12. Of late, many people, non-specifically, we give many a times actually D3 and B12. And it does help in some patients, but B12 deficiency especially is known to cause neuromuscular junction problems. And tendinitis, as you said, is common in D3 deficiency, which is correct. And tendinitis can be treated by D3, but again, one has to be sure that there is actually this is the cause. First, you can try it out with D3, because it is not very difficult to treat D3 deficiency. All are easily administrable medicines. But tendinitis can be because of other things also, like other inflammatory diseases, gout, or seronegative arthritis or tendinosis. So not all these problems are every time definable, but you can rule out serious things in these cases. And then one can come to this this remains the diagnosis of exclusion many a times, because even the serological tests are negative. These are all seronegative tendinosis or arthropathies.
There is one Dr. Jyoti who has asked one question. May I ask Dr. Jyoti, please unmute yourself and Dr. Jyoti. Dr. Jyoti, you can ask your question. She has typed the question. She has written that 65-year-old female, diabetic, complain of stretching low back pain, which is more and aggravates on lying down during night and relieved by walking. So how to proceed? What is it that?
So typically relieved by walking points towards arthropathy. So these are the typical indicators. The person with arthritis or arthropathy, facet joint arthritis, or such things, he will say that in the morning I am stiff, I'm not able to move, I'm not able to even get up properly. But once I start moving around, my pain goes on reducing. So this is a typical march of symptoms in arthropathy, arthritis, inflammatory disorders. In nerve compression problems, it's the other way around. They worsen after walking. So if you take this as a basic indicator, then you have, in this case, you have to look for types of arthropathies which are giving rise to pain. And if you are not getting the answer, it's not a bad idea to get the imaging done. Also, the serological markers for arthritis, because diabetics tend to get arthritis commonly, and because diabetes itself is an inflammatory disorder, so it is part of the inflammatory disorder spectrum. So you have to proceed in that direction.
There is one more question by Dr. Abhishek Singh. He asking when we should suspect that cause may be the inflammatory or likely ankylosing spondylitis.
The ankylosing spondylitis is, typically, as I told you, that these patients are stiff in the morning, first thing in the morning. Their pain varies according to seasons. They say particular season I am worse off, particular season I am better. Usually ankylosing spondylosis patients, if they are in hot environment, many times they are relieved. In cold environments or in sultry environments, their disease progresses. So these are some initial indicators. Secondly, in ankylosing spondylosis, the range of movement, ROM, it is reduced. So that is an indicator that you are dealing with ankylosing spondylosis. In ankylosing spondylosis, you will get affectation of multiple joints like low back, mid back, neck, all these things happening together rather than one focal point where there is pain. This is again an indicator of ankylosing spondylosis. So these are some rough indicators of angspond.
So I think we have done 1 hour this thing. Thank you very much, sir. Dr. Rekha, over to you.
Yes, sir. So it gives me immense pleasure. Can you hear me, sir?
Yes, yes.
Okay. It gives me immense pleasure to propose a vote of thanks for this webinar. We had an academic feast today on low back pain and disc prolapse. Thanks to Dr. Jayadev Panchwal, who has enlightened us on the topic in a very clear manner from a practical point of view. I thank our National President, Dr. Shahajanand Prasad Singh, HSG, Dr. Jayesh Leele, Dean, Dr. Avinash Bondwe, Vice Dean, Dr. Janmejya Mohapatra, Secretary, Dr. C. Anbarasu, Joint Secretary, Dr. Anburajan and Dr. Sanjay Patel, and all other Joint Secretaries for the excellent support rendered to make this webinar a grand success. I also thank all the delegates who have gathered here in this platform. Last but not the least, a word of thanks to the IT team who took us through without any technical glitch. Thank you, one and all.
Thank you.
Thank you. Just to remind all that the next lecture will be on 20th of May, same time, and of course, you'll be using the same link for today. Everybody is sent the link by email. Please check it, those who are not attended today. Secondly, you can definitely tell your friends and colleagues to join this even from the second lecture onwards. We can accommodate all the huge number, and of course, reminding you that the topic next will be sciatica and neurogenic claudication. Am I right, sir?
Yes, correct. This is a continuation of this spectrum.
Yeah. So thank you very much for this very, you can say, the enlightening lecture in very simple language.